What's up, Northgate? You are like primed and ready to go, my friend. All right. What's up, everyone? This is NPTE Night School episode 4. Tonight, as per the request from last week, we are going to go over non-systems and cardiopulmonary questions. I'm not convinced that non-systems is going to take us very long, to be honest, because there's not usually super lengthy explanations. A lot of your non-systems questions is going to be just straight definitions, just knowing what something is. And so we might get through these pretty quickly unless you guys have a lot of questions, in which case I took my own notes. Because like I said, with the non-system stuff, a lot of it is definitional, especially when you're going over different kinds of reliability and validity and things like that. And so even I forget that kind of junk because I don't work in research. Even though that would be dope maybe someday. But so today we're starting with 10 non-systems questions, and then I have 10 cardiopulmonary questions. If we use all of that time, yes, I'm on time today. Glad you could make it, user. So like I said, we got 10 non-systems questions that we'll go over, and then I've got 10 cardiopulmonary questions to go over. At the end, I will have time for any questions that you guys might have, and then also recommendations about what kind of topics we should cover next week. Okay, so let's jump right in. I got smarter and stopped spending money on the giant post-it note board, and also I don't have to worry about whether or not you guys can read my handwriting, because I know that my handwriting is garbage. My wife has been telling me that for the entire time that we've known each other. So I'm just HDMIing this from my Google Drive to my TV. So let's go. Jump right in. A therapist administers the same outcome measure to the same patient 1 week apart under identical conditions. Which property is being assessed? A. Inter-rater reliability. B. Test-retest reliability. C. Internal consistency. Or D. Construct validity. Take your time. Look over the answer choices again. Also got a 6.39 on my P today. Congrats, dude. That's passing. Very proud of you. That's awesome. And honestly, I don't know if your teachers tell you guys this, but this was something they harped on with us a lot. Passing on the PEAT is the greatest predictor that you will pass on your NPTE. And so if you're passing your PEATs, that is like the best sign that's going to indicate that you have the best chance to do well on your NPTE. So way to go, Austin. Okay, so if you guys haven't already, go ahead and put in your answer choice. I'll read it one more time for the people that just joined in. A therapist administers the same outcome measure to the same patient 1 week apart under identical conditions. Which property is being assessed? A. Inter-rater reliability. B. Test-retest reliability. C. Internal consistency. Or D. Construct validity. Okay, so let's go over these. Again, like I said, a lot of the non-system stuff is just like knowing the definitions of things, unless you're talking about like professional ethics or something like that. And so a lot of these non-systems questions, it's just going to be on you to make sure that you understand the differences between all the types of validities and the different types of reliabilities and junk like that. It's the least fun stuff to study. I know that for sure, but it's on the test. So A, inter-rater reliability. What is inter-rater reliability? It's the reliability that a test has if I can distribute it to a patient and you can distribute it to a patient and we can get the same score on the test, or the patient scores the same whether I'm grading it or you're grading it. So that's inter-rater reliability. Since this is talking about a single therapist administering the test, it can't be inter-rater reliability, right? Test-retest reliability. So the therapist is administering, the same therapist is administering the same outcome measure to the same patient at a different time. So that's test-retest reliability by definition, right? So B is the answer choice, but let's go ahead and go on through internal consistency. So internal consistency is a measure of reliability that assesses the interrelatedness of multiple items on a test. And so thinking about like, is there relation? So for instance, like the functional gait assessment, when you're walking and there's head turns right and left, it's assessing a dynamic portion of functional gait, right? And then the very next part on the functional gait assessment is looking up and down, right? So those things are interrelated, as would be like walking backwards, walking with your eyes closed. So that has good internal consistency because all of the items have an interrelatedness on what they are assessing, right? And then construct validity is the extent to which your test is accurately assessing what it is supposed to be assessing, right? So like the Berg balance scale, if it wasn't looking at balance, then it would have terrible construct validity because the construct that the Berg balance scale is trying to assess is balance. And if it's not assessing balance, then it's got terrible construct validity, right? So on this question, it's retest reliability. It would be trickier. This question would be trickier if one of the answer choices was intra-rater reliability, but it's not even on there. And if there's two things that would be that similar, it's not going to put them both as answer choices. Okay. All right. Let's move on to number 2. You guys see that all right? It's not too bright or anything on my TV, is it? Can you guys see that all right? Okay, cool. Thank you, Trent. Okay, so number 2, which type of validity reflects how well a test correlates with an established gold standard measure? Okay, so A, face validity, B, predictive validity, C, concurrent validity, or D, content validity. Okay, give you guys some time to reflect on that and put in your answer choices. Like I said, a lot of these non-systems questions, especially when it's asking you about validity or reliability, it's simply just a matter of knowing what the definitions are. So let's go ahead and go over it. So what is face validity? Face validity is the degree to which a test appears effective in terms of what it is aimed at. And so like, again, so the Berg balance scale at face value seems like it's going to assess balance, right? And if you start going through it and it's like, oh yeah, these things are looking at balance, then that's got good face validity because it's testing what it appears to be testing. Then you have predictive validity, which is the ability of a test to forecast outcomes that it is theoretically supposed to predict or expected to predict. So this would be like if you score less than a 40, right, out of 56 on the Berg balance scale, it says that you are like guaranteed within a year to fall, right? And so predictive validity would be that like there's been enough data behind the Berg balance scale that suggests within 1 year people who score 40 or lower fall. And so the Berg balance scale in that regard of predicting falls has good predictive validity. Trent, I'm sorry, what's that? What's predictive validity? Is that what you were asking, or what? Where you went to PT school? Oh, you went to FSC. Oh, never mind. Sorry, you guys are chatting to each other. Okay. Concurrent validity. Concurrent validity is when you take one test and you basically put it up against an already established gold standard and you try to see, do these match up well, or does this test correlate well with a test that we already know is very valid and reliable? And so the answer here would be concurrent validity because it's exactly what it sounds like, right? Concurrent means at the same time or like the same. And so if like the tug, right, and the functional gait assessment would have good concurrent validity because both of them have established norms for what would put a person at an increased risk for falling, and when they fall above or below that threshold, depending on if you're doing the FGA, it's above the threshold. If it's a tug, it's below the threshold, right? So those two would have good concurrent validity because those are both well established. The tug is in the core outcome measures on the ANPT's website. I don't believe the FGA is yet. I think the DGI still is, but the FGA and the DGI are pretty similar. And the Berg is obviously one of the core outcome measures. And so, okay, and let's go over the last one, content validity. So content validity is evaluating how well a test covers all the relevant parts of the construct it aims to measure. So if for instance, the functional gait assessment, it's trying to assess dynamic gait, right, and a person's balance with that dynamic gait. And so it's got multiple components. It looks at balance when you're just walking at your normal speed, balance when you're walking at your fast speed, balance whenever I tell you to walk fast and then I tell you to slow down. Does your balance look good with that? Balance walking backwards, balance with head turns, balance when stepping over obstacles, balance whenever you're walking up and down stairs, balance whenever you're walking tandem. And so it's got so many pieces to it of where it's trying to effectively assess it's trying to effectively assess dynamic gait, so that way we can get a good idea of, is it effectively measuring all the bits and pieces of what we're trying to measure. And so the FGA would have good content validity because it does a really good job of hitting all the different areas of dynamic balance that it's trying to assess. Okay. Shoot, this may take me longer than I thought. I thought this was going to be, maybe I'm talking too much. Do I need to stop explaining so much to you guys? Is this stuff pretty easy peasy? If I'm explaining too much, just tell me, because I don't want you guys to feel like you're wasting your time if I'm just chit-chatting away. Let's go ahead and go to number 3. Okay, thanks, user. Which study design is most appropriate for determining prognosis? Okay, most appropriate for determining prognosis. A, randomized control trial. B, cross-sectional study. C, case report. Or D, prospective cohort study. Which study design is most appropriate for determining prognosis? Okay, and I'll go over what each one is useful for. But right now, I want to know. It was concurrent. Yeah. Thanks, Trent. Like I said, I'll let you know what each one is effective for or useful for, and then I'll go over which one is the right answer. Go ahead and put in your answer, what you think the answer is. Flex those brains. I want you guys to interact, because whether you get it right or whether you get it wrong, you're solidifying this stuff in your brain when you actually interact with the material. Okay, so the more you submit answers, the more you talk through this stuff, the more it's going to help stick in your brain. And that's really what's going to be meaningful, obviously, when you get to your NPTE and it asks you a question about concurrent validity, and you're like, I remember NPTE night school, we talked about this and this is what it meant. So the more you interact with it by having to make an action, even just clicking a letter on your keyboard, it's going to help solidify that stuff in your brain. So which study design is most appropriate for determining prognosis? So let's go through each of these. Randomized control trial. What is a randomized control trial? It's taking one intervention and comparing it to usually a control intervention, right? And so it's trying to determine the effectiveness or cause and effect of an intervention. But it doesn't do a good job of determining prognosis. It does a good job of determining the effectiveness of a treatment that's being studied, right? So it's not randomized control trial. B, cross-sectional studies. So cross-sectional studies are looking at data from a single point in time, from a specific group or a single person. And because it's looking at one specific point in time, it's not longitudinal, right? And if we're looking at prognosis, we probably need a longitudinal study, so that way we can actually compare what was going on in the past, what was going on later on, and what's going on even further down the road, right? So if cross-sectional studies are looking at data at one specific point in time, it's not going to be able to help predict prognosis or determine prognosis, because you have no longitude to compare it, right? C, case reports. Case reports are usually looking at a specific individual or a small group of people, and case reports are going to be most useful in hypothesis generation, right? So case report might be like a precursor to a randomized control trial, because you might do a case report on the effectiveness of the Samant maneuver in a patient with complex BPPV, right? Complex posterior canal BPPV. And you're just checking to see on this specific individual, was the Samant maneuver effective in clearing the canals and keeping them in a vertigo-free status, right? And then later on, you might run an RCT where it's like comparing the effectiveness of the Samant versus the Dix-Hallpike in a group of 150 people with posterior canal BPPV. And then D, prospective cohort studies. So cohort studies are going to be best for prognosis. So the answer here would be D. Okay. And a lot of this stuff, I'm not going to lie to you, I don't know that I can quantify, especially with my NCS test. I can't tell you how many questions I got right because I could rule out the other three answers. There may be one answer that it's like, I don't totally know what that means, but I know what these other three things are, and it's definitely not that. And so you just get to your answer because it's like, I don't exactly remember what a cohort study is or does, right? But I know what these three are, and what the question is describing is not those three. So that's the answer. Is it best because it's prospective or because it's a cohort study? That's a super good question, Trent. Let me do some Googling real quick for us. Why is a cohort study effective for prognosis? Ability to study multiple outcomes that can be associated with a single exposure or multiple exposures in a single study. Even the combined effect of multiple exposures on the outcome can be determined, so cohort study design also allow for the study of rare exposures. So I think it's because you're getting to look at multiple variables in the cohort. And so like in a cohort study, because you can look at multiple variables, you're going to be able to study multiple outcomes with the single intervention and not just like after X number of weeks or whatever, like in an RCT. Is that a terrible answer? Would it give you an average within the cohort to best determine the prognosis? I think generally it's going to help you get an idea of like how did the cohort turn out, and there may be some outliers in the cohort that obviously aren't going to have the same level of positive effect or maybe have no effect, but you can generally see like this how a cohort responded. And I would expect that even if you don't, it might give you an average. I don't know if they exactly quantify an average, but they might, where they say like on average people in this cohort improved their functional gait assessment by 8 points, right? Or something like that, plus or minus 2 or 3 or whatever. Let's go ahead and go to number 4. A study reports a 95% confidence interval that crosses 0. This is the most important part of this question, by the way. I'm telling you that right now. 95% confidence interval that crosses 0. What is the best interpretation? A, the findings are statistically significant. B, the null hypothesis is rejected. C, the findings may be due to chance. Or D, the study lacks internal validity. It's important to remember what your confidence interval is, right? Because that's going to help you know what you're answering. So let's go over that one more time. A study reports a 95% confidence interval that crosses 0. What is the best interpretation? A, the findings are statistically significant. B, the null hypothesis is rejected. C, the findings may be due to chance. Or D, the study lacks internal validity. A, no idea. It's okay. So I don't expect you guys to know all these questions. If that was the case, this would be kind of ridiculous, right? If I was just giving you a bunch of easy junk. But another way to say this, you might see it phrased this way in questions. If it doesn't say crosses 0, then to get the same point across, it may say it includes 0. And so let's go ahead and go over it. Many of you are saying A. So I want to point one thing out, and it's just something that I think you guys ought to be thoughtful about anytime you're going over questions like this is, are two answer choices saying the same thing, right? So do you guys remember what the null hypothesis is from stats class? I'll give you guys a second to answer if you want to. Okay, so the null hypothesis is that it's always the same hypothesis, right? Is that between two groups there is no statistically significant difference. Okay, the null hypothesis means that the hypothesis is that there is no difference, right? And so you have to reject the null hypothesis if you want to prove that a treatment intervention was effective in a group that you're testing this intervention on, right? So if you say the findings are statistically significant, that means that there was a difference between the groups, right? And if you reject the null hypothesis was there is no difference. If you reject that, that means there was a difference, okay? So I just want to point out one thing that if you knew, which if you didn't, that's not a big deal. I don't expect a lot of you to have been spending a ton of time on this non-system stuff, but this one is just a little bit nuanced. So this is saying findings are statistically significant. This is also saying, B is also saying findings are statistically significant. If you have two answer choices that are saying the same thing, neither one of them can be correct, right? Because then you can't choose between the two because they're the exact same thing. So A and B can't be the answer, okay? C, the findings may be due to chance, which would mean there is no significant difference because the results that we got may just be due to chance, which would essentially say, who was it that said this? Was it Austin? Yeah, that like a p-value of greater than 0.05 would essentially mean that there were no differences between groups. But if your p-value is below 0.05, then it would be statistically significant difference, right? And then the study lacks internal validity, D. That is not actually looking at confidence interval. If something has internal validity, it's usually not related to the confidence interval or the p-value, to be honest with you. So there's three big things I want you to take away from this question, okay? And I just had this written down so you guys can copy it down like this if you're taking notes. If the confidence interval crosses 0 or it includes 0, then there is no statistically significant difference between the groups, okay? Between the intervention and the control, okay? If the confidence interval does not cross 0 or it doesn't include 0, then there is a statistically significant difference. So if you guys haven't heard of this, I would just write that down, and that's the big thing to know. If it crosses 0, it's not statistically significant. If it doesn't cross 0, it's statistically significant, okay? And just remember, the null hypothesis is the same for every experiment that's been run forever, and it's that there is no difference, statistically significant difference between the groups that were being tested. That's the null hypothesis, okay? I hated that question. I didn't even like writing that question, but are you guys still with me? Okay. I think you guys will knock this one out of the park, so don't worry about it. Which term represents the smallest change that exceeds measurement error? This one is literally the exact definition of what this term is, right? So go ahead and select your answer choices. Which term represents the smallest change that exceeds measurement error? User 1543278 says A. Austin Gordillo says D. Oh wait, I answered too fast. User 15432789 says D. Hunter Thorpe says D. I'll give you guys a little bit more time to look this over. Lou says D. It's too bad you guys can't take the boards to all together, huh? I made a joke about that one time, and one of my teachers was like, well, only if you want to split a salary between 4 of you. Okay. So, what is MCID? That is the minimally clinically important difference. And the MCID is the smallest amount of change that has to occur in order for it to be meaningful to the patient. So in order for the patient to feel like change has occurred, that's what the minimally clinically important difference is, or the MCID. The effect size is really more a measure of how well you can generalize the findings of a study to the population. So effect size is not looking at change. Well, it's not looking at the smallest amount of change to be confident that you exceeded error, right? It's just looking at how well can you generalize data to the population. C, standard error of measurement. Standard error of measurement is the measurement error, right? So it is the amount, like standard error of measure is if it's within the SEM, you can't say that any change has occurred at all because there's a certain amount of error that goes into. So for instance, between testers with goniometry, the standard error of measure is 5 degrees, right? So if someone has only made 2 degrees increase in their range of motion, you can't actually say that change has occurred because that falls within the standard error of measure, okay? And then the minimal detectable change, that is the answer. So you guys were absolutely right, D. That is the smallest amount of change that has to occur for us to be able to confidently say you cannot attribute that change to error in measurement. So that one you guys knocked out of the park. Very good. Let's move on to number 6. Which documentation practice is most appropriate when correcting an error? Could you say what MCID is again? Yes. So MCID is specifically related to the patient. So they've studied, like, let's say they studied patients performing the Berg balance scale, and they got an idea of like, well, how much change had to occur that we can quantify, right? That we can quantify that made a patient feel like they had actually gotten better or a change actually occurred. So the minimally clinically important difference is that value. It is the value of how much did their score have to change by for them to feel like a true change had occurred. So MCID is more related specifically to the patient, and the MDC is related specifically to the standard error. Well, it's related to the standard error measure. It's not the same as the standard error measure, but it's the MCID is how much change had to happen for it to be substantial to the patient, and the MDC is how much change had to occur before we could say there's no way that could be attributed to just error in measurement. Okay, so MCID, how much had to change to make the patient feel like a change occurred. Okay, and I didn't even finish that question, but you guys are answering, so that's great. I'm not worried about you all. You guys are all super students. Okay, so let me go through it. Which documentation practice is most appropriate when correcting an error? A, deleting the original entry. B, adding an addendum with date and signature. C, rewriting the note entirely. Or D, leaving the error uncorrected. I hope you all looked at D and you were like, no way, because if you ever ended up faxing notes to a doctor and that error was still present, they just got incorrect information, and that would fall back on you if it was something substantial, right? So you shouldn't, and you probably have seen this if you have ever worked in a, oh, well, if you're not a PT, if you've been a PTA and you're like going through PT school right now, you may have seen if you worked in a hospital system, sometimes doctors will addendum their notes entirely in the EMR, and you'll just see everything with a big line through it, and it'll just like, then they'll just add the correction at the bottom, right? And it'll say addendum. So you don't want to delete the original entry because it's permanent in someone's medical record. And adding an addendum with date and signature, this is the best practice. So I add whatever I made a mistake on. They see the addendum and the date and my signature on it, so that way they know when I made the change. It's going to be easier, just so you know, to make an addendum as close as possible to the date of you signing the note, because if like a month and a half went by and then I made the change and the person was suing me, I'm screwed, because then someone's going to be like, how could you have remembered a month and a half later what happened in this treatment session on 12/15/2025, right? And then rewriting the note entirely, that's not helpful, because that's a waste of your time. You already have the original note, and not the entire note needs to be rewritten, right? It's just one small part. That's an error. And then you just make the correction in the existing note. Okay, so B was the right answer. You guys are right. If you guys know people that are struggling with studying for the NPTE and you're following them on TikTok, go ahead, share the live if you'd like to. I really want to reach, because this is free, I'm not trying to get money from you guys to do this kind of stuff. If you guys feel like it's helpful, I just want to reach as wide of an audience as possible, because this is something I really wish I would have had in PT school, that like a free resource to be able to study and practice these practice test questions. Okay, so 7, a patient refuses a component of the treatment plan that is not essential to safety. What is the best action? A, discharge the patient. B, continue treatment without the refused component. C, document refusal and modify the plan. Or D, insist on compliance. So, give you guys some time. How many of these will you do you do? Are you talking about the lives or the questions, Gentry? Or sorry, Gemma? Gema? I do these lives every Sunday night at 8 p.m. Central Standard Time. I try to have at least 10 questions, and I try to base the questions off of what you guys asked me to prepare from the previous week. So last week, the people that were on my live asked me to prepare non-systems and cardiopulmonary questions. I'm happy to do whatever that's going to best help you guys prepare. I know that we have a few guys and maybe gals taking the boards in January, so we're coming up pretty quickly on those guys' boards exams, and I wanted to make sure that I was faithful to what they needed help with in the short term because they're going to be taking those boards pretty quickly. But I'm really happy to cover whatever material you guys want me to cover. So, thank you so much. These are amazing and helpful. Well, thank you. I'm glad you think so. Okay, so let's look at that question. A patient refuses a component of the treatment plan that is not essential to safety. What is the best action? A, discharge the patient. That's silly. They just didn't want to do something. Why would you discharge the patient just because they disagreed with you? B, continue treatment without the refused component. This is not a bad answer. But let's say that you are treating a patient, and as the professional in functional movement, you know what the research says on what's the best treatment approach to treat certain conditions, right? And so let's say you're treating a balance patient. And one thing that I know about the research is that balance, like let's say they have trouble balancing during their gait, which is super duper common with balance patients. Let's say that I was like, okay, I want to do some retro walking. I want you to walk backwards. And that makes them too nervous. And they're like, no, I don't want to do that. Well, I know the research says, and maybe I'll even say to the patient, like, well, what I know about the research is that it says that backwards walking improves forwards walking. And that's true. That's like actually a finding that happened. Backwards walking improves balance with forwards walking. And so if the patient is still like, no, I just don't want to do that, I'm not comfortable doing that, then it's smartest for me, because I know what the research says, that backwards walking improves forwards walking, that if a patient is just going to be non-compliant with the things I'm going to say, then as the functional professional, I should tell my notes, especially if I ever got audited by insurance or something and it was like, well, why didn't you do this or that or the other? Because that's what research says is the best approach. Then I can say, like, I did try to do that. The patient refused, as you can see in my note from 12/16, that I wanted to do retro walking, and the patient refused because it made them too nervous. So I'm not tattletaling on my patient, but I'm like saying, like, no, I know what I'm doing. I just didn't want to put my patient through that, or they didn't want to go through it, and I wasn't going to try to strong arm them because I want to build rapport with my patients, number one. But I am trying to implement good things that research says is good. So with all of that being said, I'm going to document the patient's refusal, and I'm going to modify the plan. So I'll continue treatment, and I'll do it in a different way to try to address the same deficits, but I'm going to do it in a way that hopefully the patient is more comfortable with, right? But I'm going to document that. Try to encourage patient to participate in retro walking. Patient stated due to fear of falling, they did not want to participate in retro walking. So I'm going to document that. And then insist on compliance. You can't make anyone do something they don't want to do. That's illegal. So don't do that. I mean, there's a fine line we walk between encouraging someone, like, look, your doctor wants you to get up and move. It's really important because we want you, I know you want to go home, right? And I want you to be able to go home. And so I need you to get up, because one thing I know about being able to return home safely is we have to exercise, right? We got to get up because we don't want you to get weaker. We don't want you to get deconditioned. And so I need you to get up, right? So there's a huge difference between encouraging a patient to do something and strong-arming them into doing it. And insist doesn't mean I'm strong-arming them, really, but if they're already telling me like I'm not comfortable with doing that, and I'm like, would you just do it anyway? Come on. That's not really good for me to do. Does that make sense? I spent a lot of time on that. But it's only 8:34, so we're good. Okay, I'm going to go ahead and pull up the next few questions. Which activity requires direct PT involvement? Modifying long-term goals, implementing an established exercise program, reporting patient response, or documenting treatment provided? Which activity requires direct PT involvement? And so what this is really asking is, which of these does a PT have to do that a PTA cannot do? Okay? That's really what this is asking. So which one has to have direct PT involvement that a PTA can't do, right? So that's really what this question is asking. So A, modifying long-term goals. B, implementing an established exercise program. C, reporting patient response. Or D, documenting treatment provided. Okay, this one should be pretty easy, I hope. If you guys know what the difference is in the practice acts or the scopes of practice between PTs and PTAs, it's that PTs establish the plan of care, right? PTs establish what all can be utilized in the plan of care. So like, for instance, if a PT does not have in there that, like if they don't say eSTIM or modalities, like if that's not included in the plan of care, a PTA can't just put someone on eSTIM if the plan of care didn't say that modalities were appropriate to utilize and that was going to go in the plan of care, right? So you have to have PT for that. But what this is saying is implementing an established exercise program. Well, presumably the PT did an entire evaluation and established the exercise program, right, of what we were going to work on. And a PTA can implement that exercise program, right? Reporting patient response. A PTA can take a person through exercises, assess like, hey, how hard do you feel like you're working on a scale of 0 to 10? And then report that patient response, right? And then documenting the treatment provided. Patient did 10 sit-to-stands, took a 30-second break, and then did another set of 10 sit-to-stands, right? That's totally well within a PTA scope to be able to do that. What they can't do is modify long-term goals, right? So the PT is trained in predicting or predicting prognosis. And so it's really only within the PT's scope of practice to modify long-term goals. A PTA is legally not allowed to modify any long-term goals. In fact, a PTA can't write any goals either. The PT has to be the one to write the goals. Now, in the clinic that I work in, one way that we sort of establish that is like, if a PTA sees a patient for a second visit, and let's say that I didn't assess the tug, then the PTA can perform the tug with a patient, but they can't do anything with that data. Technically, they can't interpret it as like, well, it took patient 15 seconds, and so they're at an increased risk for falls. Even though that's what research says, they can't be the one to make that dictation in the note, and they also can't write a goal based on the results of that tug. The PT signing off on the PTA's note can make a goal out of that tug time, okay? Okay, let's go to number 9. Which parameter of ultrasound most affects the depth of tissue heating? Okay, A, duty cycle, B, frequency, C, intensity, or D, treatment duration. How do you guys feel about modalities? Do you guys, if you were techs in an outpatient PT setting, do you feel good about modalities and your understanding of modalities? Do you feel like you're going to use them a lot? Let me be honest. When I was studying, sort of, but I would have just Googled it. That's funny. That's funny. When I was studying modalities, like particularly iontophoresis, I was like, I am never, ever going to use iontophoresis. I'm a neurotherapist. I knew going into school that I wanted to be a neurotherapist. And so as I'm going through school, I'm like, the only modalities I'm going to use are FES and NMES. And that's pretty much it. And truthfully, I've used IFC, I've used TENS, I've used hot and ice. I've never ultrasounded anyone, ever. But now that was because I was carrying partially an ortho caseload. I've been using modalities in previous 2 rotations. Definitely need a refresher on parameters. Yeah, that's a good thing to point out, Hunter. As a neurotherapist, I rarely use modalities, but if I do, it's going to be NMES or FES. Okay, so let's go ahead and go over this answer. So for question 9, I have to refer to my notes real quick. So duty cycle is going to affect the amount of heating, not the depth. So the duty cycle basically determines if you are trying to have thermal or non-thermal effects. And so the duty cycle is going to dictate the amount of heating that occurs, but not the depth. So the answer is not A, okay? The intensity is going to affect the tissue temperature, right? But not penetration depth. So the more intense it is, the greater heating is going to happen at the site of the head, but it's not going to have a direct effect on the depth of heating, okay? And then the duration is going to change the total amount of heating that occurs. So if I if I ultrasound for 5 minutes versus 10 minutes, 10 minutes is going to have greater total heating, but it's not going to affect the depth of heating, okay? Frequency is what affects the depth of heating. And in particular, yes, that's exactly right, Will. So 3, we usually just, I've seen like 3 or 1 on practice test questions. So they'll ask like, patient has subacromial bursitis. What do you like? What frequency do you want to use, right? And things like that. And so 1 megahertz is going to be used to get to deeper tissues. 3 megahertz is going to be for more superficial tissues. Okay, so frequency is the answer to number 9. Number 10, which parameter of electrical stimulation most influences patient comfort? This is a tricky question. I always confuse frequency and intensity. Yeah, don't get hung up on that, because intensity is going to be more in like amps, right? Especially in E-stim. It's watts in ultrasound though. So watts is intensity, megahertz is frequency, right? Okay. Go ahead and answer the question for number 10. I think this is going to be tricky. I think this one will be tricky. Give you guys a little bit more time. I'm going to go through this real quick and see who answered what. Okay. So let's go ahead and go over the answer to this. So which parameter of electrical stimulation most influences patient comfort? Now, remember, this is not specific. This is not specific to any particular electrical stimulation. We're not necessarily talking about IFC. We're not necessarily talking about Russian. We're not necessarily talking about NMES. We're not necessarily talking about IFC, okay? We're talking about E-stim in general. So that's a really important thing to keep in mind, right? Because we know that like Russian is pretty commonly or well known as like the most uncomfortable one, right? Whereas TENS and IFC are all about comfort, right? And so intensity is really going to be more, it's going to impact how many motor units are recruited, right? It is not by itself going to impact comfort most, right? So what I mean by that is a certain milliamperage of Russian may be really uncomfortable, but the same milliamperage in TENS might be totally comfortable and it might be totally fine, right? And so it's adjustable. Intensity is adjustable independent of any other variables, right? So you can adjust intensity and make it more comfortable, but that doesn't mean that the intensity was the most direct influence on comfort, because like I just said, I can have like 20 milliamps of IFC and be like, that feels good, that feels really good, and then get 20 milliamps in the same area of Russian and be like, that feels terrible. This is not the last question, Fibula. I have 10 more cardiopulmonary questions. We were just going over non-systems. So intensity is not the answer. It can affect comfort, but it's not the parameter that most influences patient comfort, okay? So frequency is going to be more involved in the type of muscle contraction that we're eliciting if we're getting a muscle twitch response versus a tetanic contraction, right? So frequency does not directly or does not most influence patient comfort either. It's going to most influence the type of contraction that's being elicited, okay? C, pulse duration. So let's go back to ramp time. So ramp time, it certainly can have some role on comfort, but what it's really doing is just like the amount of time it takes to get to the maximum recruitment that you've set up via the other variables, right? And so ramp time isn't the most influential on a patient's comfort. Pulse duration is though. So pulse duration is going to have the most influence on patient comfort, because the longer the pulse duration, the more uncomfortable it's going to be. If you have 20 milliamps of intensity going, but you minimize the pulse duration, you are going to make that 20 milliamps much more comfortable. So the answer is C, pulse duration, because the pulse duration itself, if it's a really long pulse, then it's going to be more uncomfortable. And if it's a short pulse, it's going to be much more comfortable, okay? You can adjust the rest of these independent of pulse duration, but if you don't change pulse duration immediately, number one, if it's not intense enough, you may not even elicit the size of contraction you want, right? But if you need a certain intensity to recruit the right amount of motor units, then try minimizing the pulse duration and see if you still get the contraction size you want without the discomfort. So that's what I would say. So answer there, pulse duration. Is my Wi-Fi being wiggy? Am I like cutting in and out for you guys? I just got a thing that said that my network is unstable, so I just want to make sure you guys aren't getting me cutting in and out a bunch. Okay, time to move on to cardiopulm. Fibula, don't worry, buddy. We still got plenty of time. We're only halfway through. I hope you guys like hearing me talk, because I do it a lot. Okay, number 11. Which finding most suggests impaired ventilation rather than impaired perfusion? Okay, which finding most suggests impaired ventilation rather than perfusion? Impaired perfusion. A, low SpO2 that improves with supplemental oxygen. B, elevated respiratory rate with shallow breathing. C, cyanosis with normal lung sounds. Or D, sudden onset dyspnea with chest pain. Go ahead and peruse those answer choices. See which one you think is the answer and go ahead and submit. Like I said, there's good data that shows when you actually interact with material, even something as simple as circling or hitting a button on your phone, that you actually solidify information in your brain. Okay, so if you know the right answer, hit the right answer. If you don't know the right answer, I'm telling you, if a question like this comes up and you remember, like, oh, I said it was C, but it was actually something else whenever we went over this in NPTE night school, okay? It'll stick up there, I promise. Okay, what's everyone saying? A. Okay, so let's talk about the difference between ventilation and perfusion. So perfusion is the ability of oxygen to perfuse, right, or to diffuse into other tissues to supply it with the oxygen it needs for whatever the function is it's doing. In muscles, it's contract, right? So ventilation, rather, is the ability for CO2 to diffuse out of the tissues, or I shouldn't say out of the tissues, out of the blood, and get out of our lungs, right? So perfusion is when we take in, it diffuses out of the alveoli into our bloodstream so that way it can go to our systemic tissues, right? And then ventilation is the ability of CO2 to diffuse out of our blood into the alveoli, and then we expel it out our mouth when we exhale, right? Okay, so knowing that, let's go over this question. Low SpO2 that improves with supplemental oxygen. So essentially what we're saying is when we introduce oxygen externally, right, not just from ourselves, but supplemental oxygen, my SpO2 goes up. So perfusion is the portion that suggests if I don't have enough oxygen perfusing into the bloodstream to get it everywhere it needs to go, right? So if I have low SpO2 that improves with supplemental oxygen, that would suggest that I've got impaired perfusion, not impaired ventilation. Okay? Elevated respiratory rate with shallow breathing. This is an interesting one because I'm breathing faster, right? But I'm not taking as deep of breaths, which means I'm not introducing as much oxygen into my system, into my lungs, right? If I'm taking shallow breaths. So if I'm not trying to introduce, or my body doesn't want me to take in more oxygen, but I'm trying to breathe more, the idea is that I'm then trying to expel more CO2 out, right? So I'm not trying to introduce more oxygen to my system or too much more oxygen. So that would not suggest impaired perfusion, but impaired ventilation. But let's see if there's any other one that suggests more than that, or most suggests. So cyanosis with normal lung sounds. If someone's getting cyanotic, if they're turning blue, it's because they're not getting enough oxygen. Okay, so cyanosis is directly related to lack of oxygen. Okay. Sudden onset of dyspnea with chest pain. That is not suggesting impaired ventilation or impaired perfusion. If you had sudden onset of dyspnea with chest pain, your patient is either having a heart attack or they've got a pulmonary embolism, and that's a red flag. So the answer here is B. Elevated respiratory rate with shallow breathing, because they're breathing faster, but they're not taking in as much oxygen, which means their body's trying to get more of the CO2 out. So that would suggest more impaired ventilation, okay, than impaired perfusion. Try to make sure that you make that distinction between perfusion, which is O2 being introduced into the system, and ventilation, which is CO2 getting out of the system, okay? So let's go to number 12. A patient demonstrates paradoxical breathing. This finding most suggests A, increased airway resistance, B, diaphragmatic dysfunction, C, bronchospasm, or D, decreased lung compliance. So someone tell me, what is paradoxical breathing? I will wait. I'll wait forever. I've got to go to work at 8, though. 8 a.m. What is paradoxical breathing? You all are just going to leave and I'll be waiting here forever. It's like labored breathing. That's not a bad answer. So paradoxical breathing is when no chest exertion with inhale. Correct. So I breathe in and my chest doesn't lift. I breathe out and my chest doesn't sink. So it's, in fact, it's the opposite. I breathe in and my chest sinks. I breathe out and my chest expands. That's paradoxical breathing. An impairment of accessory muscles, chest, and diaphragm when breathing. Very good, Elena. Dang, that was thorough. That was thorough explanation, Elena. So a patient demonstrates paradoxical breathing. They breathe in, their chest sinks. They breathe out, their chest rises. Okay? So increased airway resistance. If you've ever seen, oops, I just hit my mic. If you've ever seen someone have an asthma attack, they're breathing really hard to try to get all that in. And so their chest still rises. So this would be like if someone was having an asthma attack, increased airway resistance. Same with bronchospasm. These two are saying the same things. So paradoxical breathing doesn't happen with asthma attacks or bronchospasm. Okay, so it can't be A or C. Decreased lung compliance. So I breathe out and my chest opens up. I wouldn't expect that means my lungs aren't compliant, right? In fact, I would expect if decreased lung compliance was an issue, when I breathe in, I shouldn't see any chest excursion, right? And when I breathe out, I shouldn't see any chest excursion because there's no compliance, meaning that it's not There's no ability to inflate and deflate and stuff like that with the lungs. So diaphragmatic dysfunction is going to be the only thing that can cause that paradoxical breathing. Okay, because if the diaphragm isn't moving the way it's supposed to when I inhale and exhale, then you're going to see that paradoxical breathing. So many of you got this right, but the answer is B, diaphragmatic dysfunction. Very good. Do you guys have questions about that one? These usually are a little bit more complicated than the non-systems questions, because like I said, the non-systems questions usually tend to be like, I mean, they may as well just ask, well, what's the definition of content validity? But if you guys don't have any questions about that, we'll move on to number 13. Okay. Which response to exercise most indicates the need to terminate activity? A, heart rate increases proportionally to workload. B, mild dyspnea, RPE of 11 to 12. C, respiration rate increases from 16 to 22. Or D, systolic BP drops with increasing workload. This one should not be tricky at all. And you're going to have, I promise you, you're going to have questions on your NPTE that you read and you're like, oh my gosh, this is such an easy question. And that's great, because that means it took you 10 seconds to answer that and you moved on to the next one. So you can save all that time for the hard questions, right? Yeah, I don't think this one's tricking anyone. This is absolutely the one. If your systolic BP drops with increasing activity, you 100% need to stop. And it doesn't mean that you need to, doesn't necessarily mean you need to call a code or call 911 or anything. It just means if this is going down while the workload is going up, we need to stop and monitor their vitals. It's too easy, so I reread the question 10 times. You're going to get some of these, dude, I swear. And you're just going to be like, this is a chip shot. Like, there's no chance I could get this wrong if I'm reading this right? Okay, so let's just really quickly. You expect there to be mild dyspnea, right? You expect them to get short of breath the harder you're making them work. You expect their heart rate to increase proportionally. And also, if their respiration rate increases from 16, which is within the normal values, to 22, which is outside of normal values at rest, but not outside of normal values with work, then you'd expect that, right? They want you to change the answer because it's easy. Look, I will say this. I'm a proponent. Now, I don't work for FSBPT. I don't write NPTE questions for the boards. I just do it for you guys. But I genuinely believe that they are not trying to write questions to trick you. They want to make sure that you are going to be, like, their whole thing, and your school's whole thing is they just want you, they want to be confident that you are going to be safe in clinical practice. Some of those questions, because they've been drilled into your heads in PT school, because the PT school you went to needs to make sure that they're producing safe clinical PTs, this stuff should be easy. If this stuff wasn't easy, I'd be like, what is going on in that school of yours that you didn't know that systolic BP shouldn't be dropping with increasing workload, right? So that's okay, Trent. If you reread it and you're like, I just want to make sure there's nothing that I'm missing or nothing that I'm getting hung up on that's like tricking me, nothing wrong with that at all. But also know you're going to come across questions on your boards that you're like, well, that was cake. Don't worry. You're going to come up on some that you're like, what in the world is that even asking me? And that's fine. That happens. Okay, number 14. Which finding most strongly suggests decompensated heart failure? 2-pound weight gain in a day, clear lung sounds, mild exertional fatigue, or a 4-pound weight gain in a week? Let you guys take some time to answer that. Remember, which finding most strongly suggests decompensated heart failure? 2-pound weight gain in a day, clear lung sounds, mild exertional fatigue, or 4-pound weight gain in a week? Give you guys some time. Can you explain it? I absolutely will explain it. Absolutely. Oh my gosh. I'm going to try to say your name and you tell me if I'm butchering it, okay? Basant? I will absolutely explain it, Basant. That's That's the whole shebang. That's the whole reason I do this. Okay, let's see. AA, we're getting some. I got a B. We got several D's. A or D? Well, which one, Lou? Commit to one. You can do it. And even if you get it wrong, it's fine. We're about to go over it, and then you'll never forget it again. Okay, let's go over it. This one, I'm not even going to spend time going through all the questions. I will just say, if you've got clear lung sounds, that means nothing's wrong with their lungs, right? There's no crackles, there's no rhonchi, doesn't sound congested, good to go. Nothing wrong with that guy. So that would not suggest decompensated heart failure, just because it's saying you're not hearing anything abnormal, right? Oh, I was answering 13. You're good, girl. Mild exertional fatigue. That doesn't suggest decompensated heart failure. My lamps just went off, so it just got darker. Just know they're on an Amazon timer. Mild exertional fatigue would not suggest decompensated heart failure. I would be more concerned if there was like substantial fatigue at rest, but because they get mild fatigue with exertion, not worried about it. So we got to look at A and D. These are the two that we got to narrow down. Okay, so 2-pound weight. I'm just going to tell you what the values are. If a patient with heart failure gains 2 pounds in a day, that's suggestive that there's decompensated heart failure. The weekly value is 5. Okay, so if a person gains 5 pounds in a week, that is very strongly suggesting that their heart failure is decompensating. Okay, so if you see anything below 5 in a week, then that is less serious than 2 pounds in a day. Okay, if it said 1 pound in a day, 5 pounds in a week, then 5 pounds in a week would be the answer, right? But it's not. So just remember, heart failure, the red flags you got to look out for if you know they have heart failure with weight gain, if they gain 2 pounds in a day or 5 pounds in a week. Okay, so sorry, I was looking at my thumb and I was like, where did my pinky go? I couldn't find it for a second. Okay, that's number 14. We got 6 left, my friends. Which presentation most suggests chronic bronchitis? A, dyspnea with minimal sputum. B, productive cough for multiple months over years. C, acute onset fever and chills. Or D, episodic wheezing triggered by allergens. Let's see. Sorry, I quit paying attention. B. Is there a range of weight gain for a day? Hunter, I would not say that it's a range. Like if they gain 1 pound in a day, that's not incredibly concerning, but it's definitely something for the patient to be aware of. If they've got heart failure, they're likely on some sort of diuretics, like a thiazide or something, or a loop diuretic. But if they gain 1 pound, that's not super concerning. They just need to be keeping an eye on that. If it's 2 pounds or more in a day, then that's a red flag, and they need to go to the ER because if they've already gained 2 pounds, that's a lot of weight. They already have a dysfunctional cardiovascular system that can't keep up with the regular level of fluid, and so if they're getting more fluid, then they need to get that taken care of. I wouldn't necessarily say it's a range, though, buddy. I would just say if it's 2 pounds or more. Isn't it 3 consecutive months in a year? Nice job, Lou. You committed. You killed it. Yeah, you're absolutely right. Dyspnea with minimal sputum, that could just be like a chest cold, right? Not chronic bronchitis. Productive cough for multiple months over years, classic chronic bronchitis, right? Definitional, 100%. Acute onset fever chills, that's probably a respiratory infection, right? You caught COVID or something like that. Episodic wheezing triggered by allergens, that's just asthma. That's like allergic asthma, right? So B, productive cough for multiple months over years. That would suggest chronic bronchitis. Good job, Lou. Good job, everyone that said B. You guys were absolutely right, which was everyone, by the way. Nobody was thrown off by that question whatsoever. You guys have been studying your cardiopulm. Hold on, you guys just chill. I'm gonna go ask my wife if she can turn these lamps back on because it's bothering me that I'm in the dark. Hey, can you turn these lamps back on for me real quick? Yeah, just for a bit. All right. My wife got it taken care of. She's the one that has the Amazon app on her phone to control all of our smart plugs. I don't. That's why I didn't do it. Okay. What was the answer to 14 again? A. Yep, Trent was right. Answer was A. Desiree? That's funny. That's my wife's name. So if they gain 2 pounds or more in a day, that's suggesting decompensated heart failure. They need to get to the ER. Okay. 4 pounds in a week is just below the level that they usually say the cutoff is. If a patient gains 5 pounds in a week, that's suggesting decompensated heart failure. Let's go on to number 16. Got a few more. Which sign? Ooh, this is throwback to last week because we had a question about heart failure. I take my exit predictor test for my ASN on Tuesday. I have to be honest with you, Lauren. I don't know what that means. I don't know what an ASN is, but I could just be getting old. Which sign is most specific to left-sided heart failure? Peripheral edema, jugular venous distension, hepatomegaly, or pulmonary crackles? Associate degrees in nursing. Oh, dope. Well, hello, Lauren. Welcome to NPTE Night School. It's good to see you. Hold on, I gotta put a puzzle together, otherwise it's gonna shut off my live. Okay, cool. Let's see. Nothing wrong though, Lauren. You can hang out in here and answer questions, and if it's relevant to your ASN, then hang out because I just live to teach healthcare providers. Well, I mean, I live to practice physical therapy as well. Okay. Many of you, I believe, are already getting this right. So let's just go over the answers. Peripheral edema. Remember, if they have left-sided heart failure, you got to think all the blood is going to get backed up in the area that's just before that left ventricle or the left atrium and left ventricle. Okay, so I think I flipped. No biggie. So right before the left atrium and ventricle, you were getting the pulmonary venous return from the lungs, right? And so if the left ventricle isn't keeping up with the flow of blood, all that blood is going to get backed up in the lungs. Because all that blood is getting backed up in the lungs, you would expect more pulmonary deficits, right? So if it's right-sided, you're going to get the peripheral edema, right? Because you're trying to get venous return from the periphery of your body, but most predominantly your legs, because that's where gravity is going to try to pull all of it, right? So peripheral edema is backing up because the right side can't keep up. Jugular venous distension, again, the jugular vein is going to go into the superior vena cava, which is trying to drain into the right atrium, right? So it's going to back up in your jugular vein, so that's still suggesting right side. Hepatomegaly, all of that, I mean, it's just enlargement of your liver, right? Hepatomegaly is also going to be more systemic, like someone said before. Which is an issue with right-sided. Okay, so the first three are all describing complications that can happen secondary to right-sided heart failure. So the answer is D, pulmonary crackles. Remember, if we're talking about left-sided heart failure, we need to be looking at pulmonary deficits, not systemic, like outside of the lung deficits necessarily. Now, that being said, yeah, left side lung. Good job, Lauren. That being said, right-sided heart failure can often leads to left-sided heart failure if it's not treated effectively, and even then, it's a chronic condition, and so eventually, right-sided heart failure will lead to left-sided heart failure. Pulmonary crackles. So another thing to be looking out for if this wasn't there, another thing that they might say that should be cueing you to left-sided is paroxysmal nocturnal dyspnea. Right? So that's when they lay back in the middle of the night, suddenly they'll just wake up completely out of breath. Orthopnea can happen with both. It just tends to be more heavy in left-sided heart failure. If they say anything in the stem of the question about peripheral edema, hepatomegaly, right, jugular venous distension, think right side. Okay, let's go on to 17. Which single variable best predicts functional outcomes in patients with heart failure? A, resting blood pressure, B, ejection fraction, C, exercise tolerance, or D, medication regimen. Hepatomegaly is enlargement of the liver, and it usually happens because blood is backing up, so you're like blood is backing up because the right side isn't letting blood drain as effectively into the heart, and so it's backing up systemically, and so it's just like filling up your liver, making it bigger because all that blood is settling in the periphery of your body. Which single variable best predicts functional outcomes in patients with heart failure? So basically what I want you to get out of this question, it's saying if you had to look at one variable by itself, which one of them is going to tell you the best functional outcomes? A lot of you are saying B because ejection fraction can help predict functional outcomes, but not by itself. Ejection fraction usually would be in a cluster of data or variables that would tell you that it's going to be that they can predict functional outcomes, right? Now, that being said, if their ejection fraction is very low, you probably can get a good idea of like what their you can like kind of understand, maybe like predict a little bit of functional outcomes, but the biggest predictor here, single variable predictor, is going to be their tolerance to exercise, okay? Because if they tolerate exercise well, then that means that they're going to likely improve their function, right? Medication regimen is important, but just because they take their medications regularly does not necessarily mean they're going to have good, like you can predict good functional outcomes, right? Resting blood pressure may be a good indicator of their overall health, right? Generally speaking, like that may indicate like maybe they're a little bit healthier or they're taking their medications properly. But resting blood pressure is not going to be very effective in predicting their functional outcomes because their resting blood pressure may be great, but as soon as they've walked 100 feet from their master room bathroom to their kitchen, their blood pressure shoots up like crazy. But they can have a lower or an abnormal ejection fraction and still have fair tolerance to exercise. And if they have fair tolerance to exercise, then that's likely going to predict that they're going to have better functional outcomes. If they have terrible tolerance to exercise, then they're probably going to have less promising functional outcomes. So you will fail the NPTE if you do that, LOL. Exercise tolerance. Ram, you're funny. That was super funny. The answer is C. Oh, goodness gracious, that was hilarious. The answer is always B. You can try it and tell me how it works. You know what's funny is I think, so when I was in 4th grade, we were getting prepared for standardized testing, and my reading teacher was like, I just had this habit that I would always answer C. 16 is D, yes. So I think that I've internalized that, so that I've realized after last week that a lot of the answer choices that I've created, like more often they were turning into C was the right answer. And then I was like, oh crap, I gotta quit doing that because your boards will not do that. And I think I've just internalized that somehow, that C should be the right answer, but it's not always the right answer. Okay, 18. Which patient characteristic most limits long-term prognosis in cardiopulmonary disease? Which patient characteristic most limits long-term prognosis in cardiopulmonary disease? A, adherence to exercise. B, presence of comorbidities. C, younger age. Or D, early diagnosis. Go ahead and answer. Will and Gentry and Landon got their answers in. Maggie. I didn't say hi to everyone as you came in, so sorry. Hey, everyone. Good to meet you. My name's Austin. I have dubbed myself the NeuroNerd PT here on TikTok. And I love going over test questions with you guys. All right, many of you are already answering, and I like what I'm seeing predominantly. So let's talk about which patient characteristic most limits long-term prognosis in cardiopulmonary disease. If they are adhering to an exercise program, then they're going to just improve their aerobic and cardiovascular conditioning, right? Their cardiopulmonary conditioning. So this adherence to exercise wouldn't limit their long-term prognosis. It would help improve their long-term prognosis, right? Presence of comorbidities. So that one would be a limiting factor, right? Because let's say that they've got, let's say they have congestive heart failure, but they also had a stroke 3 years ago, and that led to right-sided weakness, and they still only have like 3 minus in their quad, so they can't walk as fast. And on top of that, they have like asthma or something, right? So that's going to limit their long-term prognosis, because if they can't engage in exercise regularly, then they're, because of like a previous stroke, then that's probably going to limit the like how far they're going to get prognostically. Younger age, as a general rule, if it's talking about younger age, that's a positive factor in predicting outcomes, right? In predicting prognosis. If you're young, if you're healthy, if you were diagnosed early, those are always positive prognostic factors. Could we have these questions? What is the meaning of A on number 18? Adherence to exercise. So it's saying like, this question is asking which of these characteristics of the patient is going to limit their long-term prognosis. So this, if they're adhering to exercise, like let's say they come to me as their PT and I say, I want you to walk for 15 minutes a day. I want you to do 4 sets of 8 sit-to-stands. I want you to do 4 sets of 20 calf raises. And they adhere to that exercise program, or they follow it, then that's only going to help to improve their prognosis if they can tolerate all of that, right? Presumably. So that's the meaning of A. Carolina, I will share all of these over the course of the next couple days. I did a live last Sunday, and the next day I posted all of those questions in a separate video, and you could just swipe through the questions. So yes, I will post these. Oof, I read the question wrong. That's okay, Ashley. That happens. Take your time. There's zero pressure here, right? So don't feel like you got to rush through reading the question. No biggie. Oh, I got it. Thank you. Do you do these every Sunday evening? New here. Yes, Desiree, I do. I am starting, or I have started. This is the 4th live that I've done, but I have started what I'm calling NPTE Night School, where we go over the content areas that you guys want to go over to help improve your studying or the gaps in your knowledge. And so next week, if you guys want to focus on something besides non-systems and cardiopulmonary, you just tell me, and then I'll develop some questions. Let's see. Just got here. What was number 17 and rationale, if you don't mind? Sure thing, Bo. So 17, which single variable best predicts functional outcomes in patients with heart failure? Resting blood pressure isn't going to help predict functional outcomes, because just because they have a good resting blood pressure doesn't mean they're going to have good blood pressure when they get up and do stuff, right? So like resting blood pressure may be solid, but as soon as they get up and walk across their home, maybe their blood pressure skyrockets, or maybe it tanks, right? And so resting blood pressure is not a good indication of functional outcomes. Ejection fraction, while you can generally get an idea that like a lower ejection fraction may lead to poorer functional outcomes, ejection fraction alone isn't effective enough in being able to predict functional outcomes. You usually have to look at a cluster of variables if you're including ejection fraction. C, exercise tolerance. So that's a pretty good predictor of functional outcomes, right? Because if they are progressively getting more tolerant to exercise, then that means they're probably going to be, or not probably, they're going to have better functional outcomes. Because if the more we walk 100 feet, the less they feel fatigued, the more their heart rate responds the way I want it to, the more their blood pressure responds the way I want it to, the more I'm going to be confident that they're going to get better at walking 100 feet, right? So household ambulation. And D, medication regimen. Just because they're following their medications to the T doesn't necessarily mean they're going to have good functional outcomes. And maybe they're like an outlier where if they don't follow the medication regimen at all, that means they're going to have poor functional outcomes. So anyway, that was number 17. But yes, I do this every Sunday. I want to cover the stuff that you guys want to cover. So here at the end, we will talk about what you guys want next, right? So we've got a couple more. Which breathing strategy is most appropriate for a patient with COPD during exertion? A. Incentive spirometry. B. Diaphragmatic breathing. C. Breath holding. Or D. Pursed lip breathing. I'll read it one more time for you guys. Which breathing strategy is most appropriate for a patient with COPD during exertion? A. Incentive spirometry. B. Diaphragmatic breathing. C. Breath holding. Or D. Pursed lip breathing. Many of you are answering. I like it. I like the interaction, dudes. All right. Let's go over it. What time do you start on Sundays? I start at 8 p.m. Central Standard Time. I live in Arkansas, so I'm under the Central Standard Time zone, and I always start at 8 p.m. in my time. That's because it's after my daughter goes to sleep, so I can actually, my wife and I can kind of do our own things in the evenings, and we don't have to be chasing the little rugrat around. Same, Lou said, but A is great for them. Okay, so let's talk about it. A, incentive spirometry. So incentive spirometry is really trying to improve inspiratory capacity. With COPD, they don't really have a problem with inspiration so inspiration as much as they have a problem with ventilation, which means that CO2 is not getting out of their system effectively. So improving their inspiratory capacity isn't going to necessarily help improve ventilation, right? So incentive spirometry is not the answer. Diaphragmatic breathing is the same. Well, it's not the same as incentive spirometry, but it's really focusing on using your diaphragm to expand your belly, like your belly breathing, right? Which again is going to be really focused on inspiratory capacity, like making sure we're getting a maximal inspiratory breath. So diaphragmatic breathing is out. Breath holding, probably not great, not terrible, right? Like we know that sometimes we use box breathing, but to like prevent hyperventilation. But that's more like a relaxation technique and not so much not exactly trying to improve ventilation, except that we're trying to not overventilate, right? And so breath holding isn't going to be super effective in patients with COPD. Pursed lip breathing, however, the reason pursed lip breathing is effective is because they are breathing against positive pressure, right? So what I'm supplying positive pressure within my thorax so that I can keep my alveoli inflated for longer to allow time for gas exchange, right? Meaning that CO2 can diffuse out of my blood and into the alveoli so that I can expel it. That's why pursed lip breathing is so effective for patients with COPD, because the positive airway pressure that we're implementing with the pursed lip breathing allows for time for CO2 to get out of our blood, and that will improve ventilation. And ventilation is the problem. That is what is impaired in COPD. Okay? And final question, which intervention most effectively improves airway clearance? A, pursed lip breathing. B, incentive spirometry. C, postural drainage. Or D, relaxation training. Final question. This one's for only 1 out of 20 of the marbles, so don't be too worried if you get it wrong. Many of you answering. Very good. Love it. Good job. C. Nice. Way to spell it out, Trent. C, but B is tempting. Can I ask you why? Why is B tempting, Desiree? It'll clear the lungs, incentive spirometry. I'm gonna have to memorize the numbers in your name. user 15432789. Only because in acute care, other providers will prescribe incentive spirometry as primary lung. Oh, sure. Okay, yeah. It can work, but like I said, and I think you caught this. I think you totally caught this. Really, not much to do with PT, which is why I locked in C as my answer. That's a great. Honestly, that's not a bad way to get to your answer choice. That's a pretty solid way to get there. Um, Predominantly, at least in my understanding, unless I'm totally goofed up, and just know that all of these, like the actual NPTE questions on your boards exam, have been vetted, except for 50 of them, right? It's a 250 question test. 50 of them won't be graded because they're just trying to vet these 50 questions of like to see would these make good future boards questions, right? And so 50 of them, if you're reading and they're like, this question sucks, it's probably one of the 50 questions they're not going to grade anyway. So I think it's a great option, but most effective would be the postural drainage. I totally agree with you. Incentive spirometry can help clear your airway, but again, the predominating use of incentive spirometry, at least to my understanding of why it was developed, is to help improve inspiratory capacity. So breathing in over a longer, slow breathing in over a longer period of time, right? Which can help increase time for air to get behind the sputum. But you're right, postural drainage is going to be most effective because we're letting gravity help and we're not necessarily going to be limited by the patient's inspiratory capacity. So that's another reason why this is a better answer. That's like one of the big reasons why postural drainage is a better answer than incentive spirometry, is because incentive spirometry, if we're using that as a airway clearance technique, it's going to be dependent on a person having good inspiratory capacity, number one, and number two, they have the ability to breathe in slowly to allow for the time for the air to get behind the sputum or the blockage or whatever it is, right? So if they have poor inspiratory capacity or duration capability in that regard, then postural drainage is going to be our next, or is going to be the best answer, because they don't have to be good at anything. They just have to be able to get in the right position, right? And I can facilitate that as a PT. Pursed lip breathing is not going to be effective in airway clearance because you're breathing out in a longer duration. I think I just answered that question really probably as effectively as I can. So postural drainage, you're going to allow gravity to do its thing. You're going to use percussion if you need to, some sort of tapping to help move it along in the plane of gravity. But yeah, Kate, good. Incentive spirometry, yeah, is a lung exercise used to prevent atelectasis. Yeah, exactly right. So trying to improve inspiratory capacity, right, and over a long duration of time just to maintain that inflation of the lungs. Yep, absolutely right. Okay, that was question number 20, which means that I am out of questions. And so what's the answer to 19? Answer to 19 is pursed lip breathing. So in COPD, we're looking at a ventilation issue or impaired ventilation, meaning that CO2 can't get out of our bloodstream effectively. And so which of these is going to help address impaired ventilation? It's going to be pursed lip breathing. Diaphragmatic breathing is focused more on inspiratory capacity over a longer inspiratory capacity and making sure that we're belly breathing rather than chest breathing, so that we're using our diaphragm instead of our accessory muscles. Incentive spirometry is really effective in preventing atelectasis, trying to work on inspiratory capacity and duration of time spent open and inflated. So neither of those are going to be good because getting more oxygen in isn't going to help my COPD. It's not a perfusion issue necessarily, it's a ventilation issue, right? Breath holding is more going to be like a relaxing technique if you're implementing it in something like box breathing. But pursed lip breathing, when you're pushing out against positive airway pressure, you're allowing the alveoli to stay inflated for longer, which means that you're going to have more time for gas exchange. So CO2 can get out of your blood and then expelled from your lungs. MSK next week, please, Trent says. You got it. That's like if someone asked neuro. I know that that's incredibly general. My future request would be MSK of the upper body, head, neck, trunk, or upper cervix. Okay, that's exactly what I was about to say. So next week, I can go back. Can we do neuro next week, like tracks, SCI, CVA? Rehab protocols, MSK. Protocols are kind of going to be specific to your surgeon, if I'm being honest. But we can go over like general approaches. I'll do half and half. I'll do half musculoskeletal, half neuro. It will be, Micah, it will be next Sunday at 8 p.m. I do this every Sunday at 8 p.m. You guys want to? It looks like you guys want to focus specifically on interventions in MSK though, so I'd be happy. We don't have to go. So generally, I've been trying to keep it as, and you may have noticed with the cardiopulm stuff, there's 5 domains you're going to be tested over in each system. It's going to be evaluation, prognosis, examination, differential diagnosis, and intervention. So I've been trying to keep it split up like that. But if you guys want to focus more heavily on interventions, I'd be more than happy to do that next week. I'll do half and half neuro, musculoskeletal. Neuro is cardiopulm on my weak spots. Love this. See you next Sunday. Okay, cool. So yeah, I'll split half and half. Let's do half neuro, half musculoskeletal interventions. Okay, where can I find the questions again? Sorry, Carolina. Carolina, sorry, I don't know if I'm saying your name wrong the first time or the second time. I will post these questions to my TikTok in a video tomorrow. It'll just be like screenshots that you can just scroll through and you'll have access to these questions. If you guys have questions about anything or you just want to touch base on a topic, feel free to direct message me. If you have any questions about tips for studying for the NPTE, anything like that, feel free to comment on any of my videos or you can just direct message me. I'd be happy to give you any tips or advice or talk you through anything as I have time. But I hope you guys enjoyed this session. I will see you again next week for, sorry, I forgot my name for a second, NPTE Night School episode 5. Again, I'm Austin Miller. I'm the Neuro Nerd PT. I'm happy to talk with you through anything, but thank you guys so much for joining my live tonight. I will see you all in a week, and I'll try to put some MSK and neuro questions out throughout the course of the week. Of course, it's Christmas, so I'm going to be pretty limited, but I'll work on getting some intervention questions and some neuro SCI tracks and CVA stuff throughout the week. Okay. Merry Christmas, guys. I will see you in a week.